type of that we talked about, right? The type, what was it? The type 2, right? I keep getting the type 2. Okay, so this is how it looks. This patient has drained down here to the submandibular region. So it's the same patient's clinical picture. So let me see if this will work. Yeah. So here's showing you the abscess on the video, because sometimes it's very difficult to show it on static images. So follow that thing. You see how it came from the EAC going through the parotid gland and dumping into the submandibular region. Right? So just to show you the entire tract, now let me show you here, even on the coronal, the same thing. Let me just pull it down here. So just follow that tract, follow the abscess. So you can see it goes up through and it goes to that EAC, junction of the cartilaginous and bony segments. So like I said, once you see one, all of them look the same. So you want to be mindful. So this is example of that type 1, which is parallel to the EAC, which goes parallel to it, doesn't go down to the parotid gland, but it goes parallel to the EAC. So here you can see the tract coming from the junction of the bony and cartilaginous portion, and it's going along the EAC to the auricular region. And this is the clinical picture of that patient. So both types you should be able to diagnose and differentiate. Now we'll come to the type 4 branchial cleft cyst. So any patient who presents with a deep neck abscess or a thyroid or perithyroid abscess, you have to think of a type 4 branchial cleft cyst. And it is more common on the left side. Nobody knows the reason why, but they see it more commonly on the left side. But I've seen a couple of cases on the right side too, but like they mentioned in the literature, it's more common on the left side. So here's a cartoon again showing you there's a tract extending from the piriform sinus going down. You can get either an intrathyroidal or a perithyroidal abscess. So be mindful of this imaging appearance. So this is how it looks. So here is a CT scan of a patient who presented with neck swelling, pain, fever. And here you can see that there is this abscess within and around the thyroid gland. Do you see that? So this is very typical of a type 4 infected type 4 branchial cleft cyst. And you can see how this abscess is kind of extending superiorly towards the piriform sinus. And you can see the right side piriform sinus is effaced. And if you will try to do a fistulogram or try to do scope during this time, you may not see the tract because there's so much infection and inflammation, like the tract gets compressed and occluded. So you may not be able to see the tract. So you want to treat the infection. When the infection subsides, then you can try to search for it, because then when the infection subsides, then the tract kind of opens up and then you will be able to see it. So during the acute phase, it may be difficult to demonstrate that tract. Okay, now coming to the next. Okay, so this is I think this is another patient or the same patient. I don't remember, but here you can see the same concept, right-sided. This is actually on the right side, which was the other one that also was on the right side that I showed. It's the same patient. So here you can see again that right perithyroidal / intrathyroidal abscess. You can see that extension superiorly towards the piriform sinus, and you can see that that abscess is kind of restricted on the diffusion weighted sequences. So very classic infected type 4 branchial cleft cyst. And this is actually the scope examination. You can see you see that fistula opening into the piriform sinus. So this is just showing you that. And intraoperatively, they kind of coagulated or closed that tract. So this is just an example showing that. So we talked about this. You see a sinus tract extending from the apex of the piriform sinus on barium, extending to the lower neck on barium swallow. And like we mentioned, during the acute infective phase, you may not be able to see because the tract gets compressed and occluded by the surrounding inflammatory changes. The contrast enhanced CT will show you the cyst or the abscess. And if you do a CT after barium swallow, you can see the sinus tract. And sometimes you can directly, if there is a tract that you see here, you can directly inject into the tract and also demonstrate the course of the fistula. But many a times I don't think you see the opening superficially. Okay, here's another example. This is a classic location. So you see this, left-sided perithyroid. I mean, this one, again, this is a differential. So this is very important. So you see, it's a young kid, 23-month-old, fever, left neck swelling. So you see there is the cystic lesion. It's pushing the thyroid gland. So you can see the left thyroid gland is pushed behind. So it's not exactly in the thyroid gland. It could be perithyroidal. And if you look at it on the sagittal, you'll see that it's more superior. It's below the hyoid bone. Let me see if this video works. So this is the video just to show you the axial post contrast. So let's see. So we are going down and you're seeing that there is this. You can see that it's closely related to the strap muscles. Do you see that it's located within the strap muscle? So it's so be mindful that an infected thyroglossal duct cyst can be another differential for this condition, or even a lymphatic malformation, but an infected thyroglossal duct cyst is more like a differential. So be mindful of that. Keep that in the back of your mind, especially when you see something is within the strap muscle or very close to the strap muscles. And how do you differentiate this? On MR, it becomes very easy because the thyroglossal duct cyst will be bright on T1. That's a very classic thing. I've seen it in all cases of the infected thyroglossal duct cyst. So here's an example. You can see there are two cystic kind of areas on T2. The more medial cystic area is showing some T2. It's not as bright as the lateral cystic component because of proteinaceous content. And on T1, these thyroglossal duct cysts, so they have this kind of proteinaceous content and they look like this T1 hyperintense, and they don't show restricted diffusion, even though on DWI you see it's bright, but it's all facilitated on the ADC maps. So, I mean, in this patient, obviously, this is after they got treated, so you can see the abscess has kind of come, is all the infection has been treated. But just to show you that this is how you differentiate between a thyroglossal duct cyst. And if you look at it on the, you can see that it's actually within the substance or just below the strap muscles. So it's located between or within the strap muscles and the thyroid gland. It's not exactly in the thyroid gland. So it's perithyroidal. But the other thing is that it's a little bit more superior. It's not like the type 4 branchial clefts coming from here and going down. It's like it's still up here. And as you all know, even though the teaching is that the thyroglossal ducts is some midline, when they're infrahyoid, they can be off midline. So remember that. So I know a lot of trainees actually when I train them, so but it's not midline. But remember that off midline, the thyroglossal ducts can be, below the hyoid, the thyroglossal ducts can be off midline. So be mindful of that fact. Okay. So let's move to the next. This patient was operated and this turned out to be a thyroglossal duct cyst. Now coming to odontogenic infection, this is also something you'll commonly see in kids and, very common, so you have to know about odontogenic infections. So if you want to know about, I mean, the important learning points in this case are always know about the mylohyoid line. So this is the mylohyoid line. This is where the mylohyoid muscle inserts, and it's kind of oblique anteriorly. It's more lower, and as you go back, it goes up higher. So why is it important to know this? Because you can see the second and the third molar tooth, the roots of those molar teeth are actually below the mylohyoid line. So infection of these posterior molar teeth cause submandibular abscess, whereas infection of the more anterior teeth will be in the sublingual or, like your in sublingual space. So that's why it's important to know this mylohyoid line. Also, whenever you see these infections, you always want to look at the buccal and lingual cortices of the mandible because you want to look where there's any break, and which the cortical dehiscence is more common on the thinner lingual aspect of the mandible than on the thicker buccal aspect. But that said, I've seen it on both sides, but this is what the classic teaching is, that it's more common on the thinner lingual side. Okay, so let's look at a few examples. So we'll start with how it looks on CT. You will see dental caries or periapical abscess. You will see the mandibular cortical dehiscence, and you can see evidence of mandibular osteomyelitis. So how does it look? Permeative osteolytic destruction. If it's more chronic, you can see sclerotic changes. You will see periosteal reaction. Like in this case, you can see that there is dehiscence of the buccal cortex in this case, and you can see that you can see the periosteal reaction along the buccal surface of the mandible. This was from an infected tooth. And you can see in this patient, this has been there for some time. So you can see the sclerotic changes in the mandible. Again, this is osteomyelitis, but a little bit more chronic, not that acute. This patient also has that soft tissue swelling in the buccal space, and you can see that periosteal reaction very nicely on the axial images, as well as the sclerotic changes in the mandible from osteomyelitis. Okay. That's one. This is another example of a kid who had, infected teeth. So you can see there is periapical lucencies involving the central and lateral maxillary incisors. You can see there's a subtle thinning of the buccal cortex of the right maxillary alveolus, and you can see a small, let me see if I put arrows there, small abscess over here. I don't have a mouse on this, but let me see if I can use this. Can you see? Okay. So you can see that there's a very small abscess there adjacent to that yellow arrow, and you can see a lot of swelling involving the upper lip. So this is how you want to pay attention to that. That small abscess is the red arrow. Now be mindful that sometimes these abscesses are very small, and if you're looking at it very fast, you may miss it. So, to be honest with you, sometimes I wonder if it makes a difference if a small abscess you miss because they're not going to drain it anyway. Okay, this is the clinical picture of this kid. Okay, so what is the treatment? Tooth extraction if it's a non-vital tooth, drainage of the abscess, and IV antibiotic therapy. Now coming to the very important entity which you have to know and you have to diagnose, because this can be life-threatening, because you can get airway obstruction. So that's Ludwig's angina. So this is a life-threatening infection of the floor of the mouth, and it can rapidly extend into adjacent soft tissues. It's a kind of a cellulitis that involves the submandibular and sublingual spaces, and the cause of this is an infected second or third mandibular molar tooth, and typically the organism is Streptococcus organism. And you can also sometimes get Ludwig angina from adjacent sialadenitis of the submandibular or sublingual gland. The importance is basically when you get all this inflammation and infection in the sublingual space, the submandibular space, that can cause mass effect on the tongue, and the tongue can be displaced up into the pharyngeal airway, and it can cause narrowing of the airway, and the patient may have difficulty breathing. So that's why you need to pay very close attention to the airway in these patients. So when is imaging? What do we look for in imaging? To look at the airway patency, we want to look for the presence of gas forming organisms. You can look for underlying dental infection. And if there's a drainable abscess, you can tell the clinician or physician or the surgeon about it. So here's a patient who had extensive look at the sublingual space and the submandibular space. And this is with gas forming organisms. You can see a lot of gas over there. And in this case, you can see that the tongue is kind of displaced up, and you can see that the airway is completely effaced. So this is something you have to communicate to. You have to pick up the phone and talk to them and tell them that this is impending, the airway is obstructed. Okay, this is a young kid. Again, you can see on the topogram, you can see the swelling in the sublingual and the submandibular space. Again, there's no abscess. This is diffuse cellulitis, and you can see it kind of is you can easily see where this infection can go up and cause narrowing of push the tongue up and cause narrowing of the airway. In this case, the airway looks patent yet, but this was the initial scan on this patient. You can see how this looks, and on the follow-up, you can see it's gotten worse. A lot of swelling, there's fluid, but it's still there's no abscess or no drainable collection. In this case, because the floor of the mouth is not involved, there's not that much airway obstruction, but you can see if the floor of the mouth was involved, you could see how quickly the tongue would have been pushed up. Here also you can see the tongue is slightly pushed up, but the airway posteriorly is still open. Okay, so treatment, you treat them promptly with antibiotics, and you have to manage the airway. Okay, now coming to suppurative lymph nodes. This is lymph nodes that enlarge and then liquefy secondary to an infectious process. The organisms most commonly are staph and strep, and this is how it looks. So you see here, basically you can see conglomerate lymph nodes around this big collection, which is peripherally enhancing. So your question can be to me, how do you know that this is not a branchial cleft cyst? That's a good question. I also know that because I can see multiple lymph nodes matted together, and this looks like within that conglomerate lymph node there is an abscess. So that's how I know that this is probably a suppurative lymph node. But that said, look at the thickness of that wall. It's very, very thick. So it tells me that it's probably just a matted lymph nodes or conglomerate lymph nodes, and that nodal necrosis or suppuration has occurred internally. And this is a suppurative lymphadenopathy. And in this patient, you can also see that retropharyngeal effusion. Remember, we said that retropharyngeal effusion, any kind of neck infection, if adjacent neck infection, can cause a sympathetic effusion. So you can see that here in the middle image. Where you can see that around the carotid vessels, you can see that retropharyngeal edema or effusion. Okay, so just showing you that yellow arrow is the retropharyngeal effusion, and then you can see the internal jugular vein is compressed, but there's no thrombophlebitis yet. Okay. So here is showing you an example of a suppurative jugulo-digastric lymph node on the left, and you can see an infected branchial cleft cyst on the right. But this, again, like I said, it may be difficult to just to make out the differentiation just if you are starting. But if you over time, when you see more and more cases, you'll see the difference. You can see on the left side, it's like this kind of conglomerate group of lymph nodes, and you can see that within the center of that there is suppuration, whereas on the other side there's just that one lesion, and then there's peripheral enhancement. That's how you know the difference between the two. Ankita, am I good with time, or am I good with time, Ankita?
Ma'am, I think we're fine, ma'am. That's fine.
Okay. Yeah. Because okay, fine. Okay, then I think I have 5 more minutes, so I'll try to cover 5 or 10 minutes. How much time do I have, Ankita?
You have like 20 minutes, ma'am.
Oh, 20 minutes. Okay.
Yeah,
I thought it was okay. So now coming to dacryocystitis, this is inflammation and dilatation of the lacrimal sac, and most commonly it's because of obstruction to the nasolacrimal duct. Clinically, these patients present with a medial canthal mass lesion. You can also get surrounding inflammatory changes in the periorbital soft tissues, conjunctivitis, as well as purulent discharge. So this is how it looks. So this is a CT in a patient who presented with this medial canthal swelling, and you can see that the right side there is periorbital soft tissue swelling, as shown by the yellow arrows. You can see that small, peripherally enhancing, lacrimal sac which is infected and it's inflamed, and you can see the peripheral enhancement. And you can see if you look at the two nasolacrimal ducts on both sides, you can see that the right side nasolacrimal duct is enlarged and completely opacified. So there's some kind of distal obstruction, and that was the cause of this dacrocystocele as well as dacryocystitis, secondarily infected. Okay. This is the clinical picture. This is another example. Here again, you can see peripherally enhancing hypodense collection in the right medial canthal region, and you can see the right nasolacrimal duct is slightly enlarged and completely opacified. So that tells you that there's some distal obstruction. That's the most common cause of the dacryocystitis. Okay, so this is an example of, this is not dacryocystitis, this is just this is dacrocystocele. You can see very large medial canthal mass lesion going down all the way along the nasolacrimal duct to the to the inferior meatus. So this is classic appearance of a dacrocystocele. Okay. Okay, so we talked about this, all the imaging findings, hypodense lesion with peripheral enhancement, and you can see that the complications, so periorbital or orbital cellulitis. So you can see that, and then from the periorbital region, it can extend posteriorly, but most commonly it is restricted to the preseptal space. Okay, now we'll talk about gland infections. We'll start with the parotid gland, then we'll look at the submandibular gland. So acute parotiditis could be bacterial, viral, or related to a stone. If it is bacterial, the common pathogen is basically S. aureus or anaerobic bacteria. And what are the complications? You could get abscess formation. The retromandibular vein is in the parotid gland, so you could get thrombophlebitis of the retromandibular or facial vein because it goes and joins the facial vein. And it's very dangerous because once it goes to the facial vein, it can go back and go into the cavernous sinus, right? And because the facial nerve is within the parotid gland, you could get cranial nerve 7 dysfunction. So here's an example, a patient with right-sided parotiditis. You can see then the parotid gland is enlarged, is asymmetrically enhancing. A lot of cellulitic changes in the adjacent soft tissues. You can see stranding of the subcutaneous fat. You can see thickening of the overlying skin. A lot of lymph nodes around the periphery of that lesion. So this is basically acute parotiditis. And again, you can see that ill-defined margins. And you want to pay attention to see if there are any kind of low attenuation areas within this that suggest an abscess. And the red arrow is showing you that there's an early developing abscess over there. You can see a little bit of peripheral enhancement that might need to be, the surgeon might have to go in and drain it. Okay, this is another example. Again, in this case, the abscess is much more apparent. So you can see the parotid gland is asymmetrically enlarged, inflamed, and there are these collections within the gland suggestive of abscesses. And whenever you see unilateral parotid or any kind of salivary gland infection, always pay attention to the duct, right? So you want to make sure that you're not missing a stone, and this is not secondary to a stone. So I've seen this being the common mistake. People don't look for the stone. So always look for the stone, even if it may not be, but at least you're excluding that out. So if it's in the submandibular gland, you want to go along the entire tract of the submandibular duct. If it's along the parotid gland, you want to go along the entire tract, so you want to look very closely. Sometimes the calculus is right by the opening of the Stenson's duct, which is close to the bone, and you may not see it unless you window it properly. Okay, another example. And now, so what is the other differential for this kind of parotiditis with this kind of an abscess is basically a type 1 branchial cleft cyst, right? So keep that in mind also. But like I showed you in the type 1 branchial cleft cyst, pictures, you always want to make sure that see if it goes up to the EAC, see if it goes down towards the submandibular gland. You want to look for all those features. This looks very different. It doesn't have that tract going up towards the EAC. So then you can also get viral parotiditis. Usually they are bilateral. And in those kind of viral cases, you can also see involvement of the sublingual and submandibular glands. And then causes are mumps, obviously, and mumps is most common. You can also see it with other viruses, but mumps is more common. So here's an example of a patient who had unilateral. This was a viral case. So you can see over this patient had complete right facial paralysis and upper lip rash. So you can see the right parotid gland is slightly asymmetrically enlarged. And you can see that it's more T2 hyperintense. It's enhancing slightly more than the other side. And if you look, there are mildly enlarged intraparotid lymph nodes, also some lymph nodes in the right jugulo-digastric chain. And because of that history of right facial paralysis, I looked very carefully at the mastoid segment of the facial nerve. And if you can see the right side, it's slightly more prominent. You know, the mastoid segment normally enhances, but you're looking for asymmetry, right? So you can see that the right side is enhancing. So that suggests that there is some neuritis in along that because of the inflammation in the gland. Like we talked about, one of the complications is facial nerve involvement. So in this case, there was facial nerve involvement. You can see that there. And then these lymph nodes we already talked about. And treatment, basically hydration and antibiotic therapy. And if there's an abscess, you drain it. So what about the other salivary glands? So basically, you see the same findings: enlarged and enhancing gland. You see surrounding cellulitic and myocytic changes, and many a times you want to, like I said, you always want to look at the ductal dilatation and you want to look for that stone. So let's see. I'll show you an example. This one basically right submandibular sialadenitis. You can see the enlarged and asymmetrically inflamed right submandibular gland, surrounding inflammatory changes. I will always follow the submandibular duct to make sure that there is no stone. This one didn't have a stone, but you can see here there are some lymph nodes which are compressing on the IGV. This is an example of a stone. So you can see the left submandibular gland is asymmetrically dilated. It looks like the submandibular duct is dilated, and I don't know if you can see there's a filling defect on the left side, that is a stone. I've shown you on these coronal images, the left submandibular duct is enlarged, and you can see that filling defect or that hypodense structure, that is actually the stone. So sometimes on MR, if the patient is getting an MR, it may be hard to see it. You see it like a ghost within that, you see it as a black structure within, on the T2 weighted images within the duct. So pay attention to that, because many people don't look for it on the MR because they think they can't see it. You can see it. And sometimes you can also do heavily T2 weighted sequences like Fiesta or KISS, and you can see it. So if you are on the, if the technologist has called you, so you can ask them to add those sequences. That's also something you could do. Or if you're monitoring the study, most of the times I'm monitoring a study, I'll see it, I'll ask the technologist to actually add that to the protocol, and then they'll do it. Uh, so obviously CT is better to see it, but sometimes patient is getting an MR, you can still see it. You can recommend a CT, and because you can have multiple stones, and you may not be able to see small stones on MR. It's better seen on CT. Okay, so we saw that. Coming to Lemierre syndrome, this is important to diagnose. Uncommon. I've seen only 1 or 2 examples of this in my lifetime. Uncommon, potentially life-threatening complication. This occurs following an upper respiratory tract infection. So usually patients have a sore throat, then they present with, like this cord-like swelling along the external jugular vein or internal jugular vein. And then from there, they can get all these metastatic complications. I'll show you before that, the causative organisms. Over here in the US, they ask this in many exams. What is the causative organism? It's Fusobacterium necrophore. So this is how the infection spreads. So you have basically an upper respiratory tract infection or tonsillitis, adenoiditis. From there, the organisms spread from the tonsillar veins into the IJV or the EJV. The bacterial endotoxin induces platelet aggregation and septic thrombus formation, and then those septic emboli can then go into the lungs, liver, endocardium, or joints. So here's one example that I have seen. So this patient had a sore throat a week or 10 days back. And then they came in with this kind of cord-like swelling along the neck, pain along the neck. And you can see that there is a non-occlusive thrombus in the left internal jugular vein. And if you look even on the left side, you see that even the external jugular vein is also, I don't know if you can see it. You see the external jugular vein here in the second image, that is also completely occluded, and you can see that the color Doppler shows the thrombus, and then you can see these metastatic lung abscesses, right? So you don't want to miss this out. Okay. I think that's it from me. I have airway obstruction, but I think that's not exactly infection. So I'm going to stop right here. We'll see if we have any questions. Yeah, I've finished at 45 minutes, right, Ankita?
Yes, ma'am, we're very comfortable with the time.
Right, yeah. So if any